I would like to invite Dr. C.E. Epen to moderate the next talk titled Use of PLEX in a Secondary Hospital Setting by Dr. Uday Zachariah.
Friends, we'll move to now the second topic on this session, and may invite Dr. Uday Zachariah to take up this topic, the use of plasma exchange of PLEX to treat liver failure with relevance to a secondary hospital setting. So Dr. Uday Zachariah is a professor in the Department of Hepatology at CMC Vellore. And I know that the 2 years he spent in Odanchitram in the Christian Fellowship Hospital doing his UG bond has impacted his thinking, and often his language he speaks is a secondary hospital level language. So Uday will touch upon our experience of using PLEX to treat rat poison, which is a common form of committing suicide in our part of the world, and showing an equitable, accessible treatment which is possible in different secondary hospitals. Uday, over to you.
Thank you, sir. Thank you, sir. Thanks to the Department of Medicine for allowing us to share our experience and participate. I just want to start with a story. This is a patient, name has been changed, the young girl. She was about to write her 10th standard exam, and at that time COVID hit, and her father had a roadside shop. She had a younger sister and a mother who was a homemaker. The roadside shop failed during COVID time. The money lenders came, and there was no hope for the family. So the father decided to end the life of everyone there. So as a farewell gift, he bought ice cream for everyone and laced it with rodenticide or rat poison. And so everyone took it and went home, and nothing happened. So this young girl got very upset and said, "You can't even do this right. I'll sort it out." And then I don't know whether it was the next day or sometime later, but they did it again. And this time, the youngest, the member of the family, that is her Ahila's younger sister, passed away. Mother was admitted, and after 2 hospitals, Ahila reached CMC in liver failure and was unconscious. Thankfully, we were able to rescue her at maybe about 1/20th the cost of a transplant. So this is just one of our patients, and so many patients like this reach all of y'all at different times. So with that background, transplant is not accessible to everybody, easy to say. So we started looking at what are the other options where we can rescue these people. And this is what I'll focus the talk on. I'll move quickly through the slides, so forgive me, and we can discuss it later to save time. So plasma exchange is known by different terminologies. We prefer the term PLEX. It's been standard of care for different indications in the nervous system, blood, kidneys, well established. Now more and more the evidence is accruing for use of it in the liver as well. So for us, plasma exchange is different from plasma pheresis. Pheresis is removal of the plasma. When that removed plasma is replaced by a fluid, we call it plasma exchange. For us, in liver failure, the replacement fluid is fresh frozen plasma, as it provides the coagulation factors and other things. So just a short note on acute liver failure. For us, liver injury, severe liver injury is when you're jaundiced and your coagulation factors are markedly off. And to add to that, if you develop unconsciousness, that's liver failure. And if you have an underlying liver which is already not pristine or normal, then you have an acute or chronic liver failure. So most of the patients who reach us are in an acute severe liver injury and beyond. So essentially, extremely sick patients. So with this, this plasma exchange technique, the first person to actually do an RCT and try it out was from Norway. We just saw that Norway has a very probably one of the best systems. So Larsen is who did it, and he used a high volume exchange. Now remember, our blood volume is about 5 liters, of which approximately half is our plasma volume. And so 4 times the plasma volume was circulated in Larsen's study. Subsequently, the amount of volume which was replaced came down by Raki Maiwal, again our student now in Delhi. And what we follow here is an even lower model where we use 0.5 or half the plasma volume. So our strategy is to use a low volume. So Larsen in his RCT was able to show those who were not for transplant in that country. He was able to show that with the use of plasma exchange, there was a survival benefit. And he postulated that this may be because of a decrease in the multi-organ dysfunction. And with that, it became a class 1 indication for plasma exchange now. And low volume PLEX hopefully is going in the same direction as high volume PLEX. So with that, we come back to Ahila's story. Is Ahila an exception, or is this commonly seen? So a study done with the Tamil Nadu Society, Indian Society of Gastroenterology, of which Dr. Eapen was a part of, we looked at what was the paracetamol poisoning. Most of us have read in books about paracetamol poisoning. But what we showed in this study, or what was shown, is that for 450 patients with paracetamol poisoning, for 450 patients who came with rodenticide, there was 6 paracetamol overdose. So the ratio is 75:1. So at least in this part of the country, the toxin is not paracetamol, it's rodenticide. Further, when these patients were looked at, 75% were of this young age, 15 to 30 years, and 35% of them died of a DAMA, so extremely high mortality. And how many of them actually reached a transplant? Remember, Tamil Nadu is one of the pioneers in liver transplant in both the government and the private setting. Only one of them reached transplant. So practically, urgent liver transplant is not feasible for 99% of patients, more than 99% of these patients. So that was the problem. On the other hand, about 1,000 transplants are being done in India. A little less than 100 are being done for these indications, acute liver failure, with extremely good survival rates. But if you look at 1,000 transplants being done, it is estimated that in Tamil Nadu alone, 1,500 plus had rodenticide toxicity, and the outcome, as I showed, was found to be quite bad. So with this, we go back to the Kochi group, which actually started work by doing transplant for these patients and came up with their criteria. Some of you all as medicine PGs will be aware of King's College criteria, which is applicable to the West. The Kochi criteria was specifically made for patients with rodenticide toxicity. And those who are familiar with scores of this will realize that this is a very high score. So believe me when I tell you that these patients with this score are extremely, extremely sick patients. So the Kochi group showed that with standard of care, all of them were dying. And with liver transplant in that small group, they were able to rescue about 86% of them. In our preliminary work, which is now expanding, Leenath Thomas was able to show in the younger group of patients, those who did not undergo transplant because there was simply no option for that in all these patients, those who underwent PLEX, we were able to rescue 75. And now that is about, as the numbers have grown, it's around 66%. So from a situation where majority of the patients were dying, we were starting to see that majority of the patients are surviving. And it was a matter of pride for us that this paper, the editorial, was written by Larsen himself. So with that, criteria were brought out, and we said that we need to do it early. not late. The later we do things, the less likely we'll be able to put out the fire. Sounds logical. So we said that anyone who has a deranged LFT and starts having a coagulopathy, that's the time to do plasma exchange. When not to do it is when the patient was too sick, very hemodynamically unstable or actively in sepsis. So this was then came out as the guidelines of the Tamil Nadu Society based on the data we were able to provide and through the society. It didn't stop there. So with that, what was being done after that? So on the left of your screen, you will see Dr. Dairas Ahmed, IAS. He is one of the speakers today. He was then in the post of director of the Tamil Nadu Accident and Emergency Initiative, the THAI, as part of the National Health Mission, THAI NHM. So he was able to pick up this information and moved quickly. And along with the people on the left, you can see Dr. Eapen there and Dr. Narayana Swamy, who is a hepatologist and now the uh, Vice Chancellor of the Tamil Nadu Medical MGR University. So together, I won't go into the details, but together with work, a standard operating procedure to manage these patients was brought out, a guideline was brought out where a hub and spoke model. So the initial management of acute poisoning was done in the PHC and then referral to a secondary level center. And in that secondary level center, the first thing was don't discharge these patients because the toxicity comes a few days later. Watch them, and if their LFT becomes abnormal, LFTs are now available in any biochemistry lab, then refer them to the district hospital. All hospitals, all medical colleges in Tamil Nadu district, starting with 6 chosen medical colleges, were given PLEX machines by the government. Where did these PLEX machines come from? It was actually bought for COVID. And after COVID, when the machines were not being used. So then suddenly a new indication came and they were offered this. So the hope is that every district will now have one medical college which will be able to offer this service. We went further and with the help of Dr. Dairas Ahmed and team, as part of a CMC THAI initiative, we started training. We had an online and a contact course. And that at the bottom is the first group from Coimbatore Medical College, which is now actively doing it. And so far, we have been able to train about 700 plus healthcare workers. Even more, the government of Tamil Nadu was able to pick up this information. And in a GO in December 2022, they restricted easy access to rodenticide. Now, you may say that's a drop in an ocean, but it was picked up by the government and the right steps were being attempted. So with that, where are we so far? So if you look on the, again, to the left of your screens at the bottom, so far we have information, this is the end of 2022, that 652 patients were able to undergo plasma exchange, but only 2 underwent transplantation. Now it's for us and the government to assess the mortality and survival benefit. So coming back with this information, what we learned over time is we need a team. Now, who is part of the team is not very important. It is the members of the team. You need an admitting team. Now, the admitting team can be anybody in your setup, whomever is willing, or as was said in the initial part of the program in the inauguration, whoever has a passion and feels for this is part of the admitting team. Then you need a technical team. Everything is a teamwork. So you need a team who will be playing good cricket with you, I guess. And the nurses, technicians, everybody together form the team. And this, I think, is the model that has helped us so far in CMC. So this was about rodenticide. Another problem with hepatologists face, it's all environmental hits. One is toxins. The other toxin for us is alcohol. It's a big problem. We can't wish it away. We can't sweep it under the carpet. We have to try and look after these patients. The mortality for alcoholic, acute alcohol, or severe alcoholic hepatitis is extremely high. There are no good therapies for it worldwide and other than transplant in some centers. So we looked again, Santosh Kumar, again a product of the Department of Medicine from here, looked at it, and we were able to show that at 1 year, this is again preliminary data, it's now been sent for with larger numbers for peer review, was able to show that compared to standard of care, plasma exchange seemed to work. More importantly, Santosh was able to show it's very important as to the technique that you use. There are different techniques, membranous and centrifugal. I won't go into the details, but in a nutshell, membranous is like running running blood at a very fast rate, at a high flow rate through a membrane and hoping to pick up block the toxins at the level of membrane and then pushing the blood back into the system. Versus centrifugal is, as I understand it, a very slow technique where you churn the blood slowly, remove the supernatant and put back the cells. So one essentially, one is a very slow, gentle technique. The other one is a more fast and aggressive technique. And as you can see here, for us in liver failure, the centrifugal technique was, you can see the difference. I always liked it was like this, not like that. It was like this. So that was huge learning for us. So with this, we have been able to now, we started early and you can see that our numbers have been growing. Our experience is growing over the years and we have reached more than 500 patients who have undergone plasma exchange so far in Vellore. With this, we started asking some more questions. Can we now start improving safety? Can we reduce cost? What is making the difference? Why are these patients surviving? So one of the things was blood products. We can't indefinitely keep asking a blood bank for blood products. And remember here, the blood products is plasma, which is usually thrown away. We are not using any other RBC. So anyway, we looked at this. Initially, we used to follow standard of care and give blood products even while putting for the insertion of the port. We changed to a restricted transfusion strategy and we just stopped using blood products as far as possible. With that, we were able to cut down. So prophylactically now in Vellore, we do not use any blood product prior to port insertion, and we use the FFP exclusively in low volume during the procedure itself, not prior, not after. The other doubt was, oh, you're giving a lot of blood products. These patients are prone to transfusion-related complications, either circulatory overload, and all the other complications. So Vijay Alexander, again, a product from Department of Medicine, was able to show that actually our risk in the patients who were not ventilated, that means who had not yet reached ventilation. You can see on the top, out of this 290 odd patients, 250 were managed in a HDU. Very, very few patients were sent to an ICU. This is another mantra that we follow. Try and give the best possible care in the ward. Try and avoid shifting the patient to the ICU. So majority of these patients were not ventilated. They were managed with excellent monitoring in a ward setting. They were all very sick. And as you can see, there were more than 6,000 transfusions here, low volume per patient, and very low rate. 1.7% of them actually developed breathlessness. And on evaluation of that, only 2 of them had circulatory overload. Nobody had Trali. The others all had reasons. Of the total 5, had some reason for a pre-existing liver lung issue. So we were able to show that we can safely give low volume blood products without or with extremely low risk of injury. Then we started asking ourselves, when we put the port, we had to train ourselves, how do you put a port, a central line? This is not feasible in every setup. Most secondary level hospital setups now will be able to put a port, which is just a central line. But still we asked, can we do it without a central line? So we found roughly, I can't show you all the data, Ashisha, again from Department of Medicine here, was able to show that about 1 in 5 patients, we will be able to do a peripheral plasma exchange. So look at the circles in red. So the gauge of the needle, the majority of them had an 18 gauge needle. Anybody who's worked in casualty can put an 18 gauge line. So we were able to demonstrate that the majority of procedures, not the majority of procedures, in the majority of patients whom we were able to do peripheral plasma exchange. We could do it with a normal IV cannula on both arms, and most of them we were able to complete the procedure without having to shift to central. And again, we were able to show that efficiency and efficacy was exactly the same. Um, hopefully this data will come out in a bigger way. So in essence, the patient first comes without spoiling all the IV lines. And if we can keep the IV lines pristine in the cubital fossa, and then few days later, if the patient needs a plasma exchange, we can safely and easily do it using a peripheral IV cannula and saving another about 8,000 rupees on a central line. This data also to show that we didn't find that hypocalcemia was an issue. For lack of time, I won't show that. So we were able to show all these things, but how is this helping a patient? What is the hypothesis? So really, this is the liver. You can see the sinusoid. The difference between the endothelium and the sinusoid is the sinusoid has pores or gaps where the portal blood is able to get through into the hepatocytes, and there are villi there which increase the surface area about 1 lakh times, and all the good stuff or bad stuff from the portal circulation is able to get through these pores or sinusoids to the hepatocytes for absorption and then processing in the hepatocyte. So we feel that if these sinusoid pores are blocked by macromolecules, inflammatory cells, all the debris which clog these fenestrae, then there is a two-way traffic is blocked, and therefore the liver is just not going to get fed, neither is it going to be able to excrete. So we feel that the focus should not be on the hepatocyte per se, the focus should be on the entry-exit process, that is the lumen. So most of these slides, by the way, are from my boss, Dr. Epen. And this is, I think some of you all would have seen this cartoon. This is the front of our hospital. So those of you who came in at maybe 7 o'clock, it would have been free. But by 8 to 9, it's fully blocked and nobody can move anywhere. But the moment the traffic jam is declogged, then it becomes easier and smoother for everyone. Everyone is not stressed and more relaxed. Everyone can do their work. So one of these clogging molecules is possibly a von Willebrand factor. Von Willebrand factor, most of us are aware of the deficiency which causes bleeding, but in liver disease and indeed in other systemic infected and inflammatory conditions, it is the excess which causes a problem. So the von Willebrand factor is a very large molecule and normally cannot be removed by a membranous or a dialysis technique, which is why we prefer the centrifugal technique. It's the largest known plasma. It's an endothelial protein. When the endothelial is activated and injured, this endothelial protein comes out, it opens up, and as part of it starts the coagulation cascade, primary coagulation cascade, and platelets tend to come and clog onto it. So there is a localized or an organ specific and then a systemic, you could say, congestion. So our focus is on trying to ameliorate the organ dysfunction and ameliorate both the activation of the innate immune cascade and endothelium. So when it is just activated, the reticuloendothelial system, patient is asymptomatic. When it is overactivated, there is organ failure. So it makes sense that when it is activated and the patient there's a tendency to become overactivated, intervene at that point. But what are the markers for that? We don't know yet. We are working on that. I'll leave you with some pictures from our EM facility, which as part of the hypothesis, this is a postmortem picture of a patient who died of rodenticide toxicity. And I'll try and show you. I don't know if it's... So that is actually the sinusoid with platelets here which are clogging it. So one of the hypotheses what we were able to sort of at least see in this patient, the sinusoids being swollen and is being filled with platelet plugs. And further activation of the coagulation cascade has caused these fibrin tactoids, which is again activation of the coagulation cascade. And the best picture that I liked of this inflammatory cell, the macrophage, like a claw, crab-like claws coming out and trying to engulf the RBCs and contents of the uh, lumen. So it was very exciting to see that some of the hypotheses that we have or had are coming about. A lot more needs to be done, but this is where we use it today. Certainly for rodenticide. For rodenticide, no doubt. For alcohol, yes, evolving. And with other drug-related injuries, we have a recent paper out from Kunwar Ashish Singh, who's now in Delhi. He has shown that it can be used in drug-induced liver injury, and there is a small work from here on viral as well by Vijay Balaji. So I won't go through these rules; they are all available here. But I would leave you with this line of I like saying this: what has worked for us, what is different that has not worked in other centers, is that we went low volume. We went very slow. We didn't do it at a high rate, which is what we feel. I wish we knew this in COVID time. We didn't, and we decided to do less. Less is more for us. So low, slow, and less is our mantra. Everything else will follow from there. So this is a picture I just took yesterday in our ward. It's a normal ward, and we have a little more monitoring there. And in that, you can see that this plasma exchange machine is wheeled in. We don't need any lines and fancy fluids coming. This can be wheeled in and out, so we are able to bring the procedure to the patient and not shift the patient. So it's just to show that it can be done in any ward, really. All you need is some expertise and enough passion. This is the team that we have with us, and many of them are from the Department of Medicine. So again, thank you for allowing us to share. We feel that this has implications beyond liver failure. I will ask opinion from Dr. Eapen or the audience on that. And we would like to, anybody in the audience who's watching, who would like our help to set up or train, we'll be more than happy to do it. So thank you.
Thank you, Uday, for covering this exciting new advance. So I would just like to highlight the point which Uday said, that we think we are not removing the poison, we are attempting to dampen the inflammatory response. So that's what we think is happening. So we can consider PLEX as an anti-inflammatory therapy. That's our sense of it. One question has come in, Uday, if you can bat it. If rodenticide kills due to the phosphorus contained in it, could white phosphorus used as a tracer in Gaza cause case of liver failure in Gaza? White phosphorus, part of the Israel war, do you think it's causing liver failure there?
I don't think I'll be able to truthfully answer that. But all I can say is I hope that in Gaza things work out correctly, and they also start discussing the things that we are discussing. That's more important.
Sure. One more point in that, really, to that question. So what we are seeing here is yellow phosphorus that is ingested and causes liver failure, while white phosphorus is reported more in North India, where it causes acute pulmonary problems and people die of pulmonary failure, which happens even before liver failure sets, which is 3 to 5 days later. I think we can take one more question, then we'll close. Thank you. Okay. What is the cost comparison between PLEX and liver transplantation? Uday.
Sorry,
cost between
cost
PLEX
comparison.
and cost of liver transplant.
I guess it depends on where you get the transplant done. If it is done in CMC, it will cost between 12 and 15 lakhs at present. In the government systems, it is about 12 lakhs. The cost of a plasma exchange in CMC is between 75,000 to 1,25,000 at present. And we hope that it will come down over time.
So one session of plasma exchange costs 20,000 rupees. And we usually do 3 sessions of plasma exchange. So you're referring to the hospital bill is what you're saying will be?
Total hospital bill.
Will be about 1 lakh.
Yeah.
Okay, I think we'll close this topic. Thank you, Uday, for this very nice session.
Thank you, sir, for the enlightening talk. I would like to request Dr. Eapen to present the memo to Dr. Uday Zachariah.